Associate Principal, PhD College in Coimbatore, Tamil Nadu from India, Dr. A. Jayasudha. The program coordinator stepped in to organize today's international webinar. The most valued participants, we hope we make your day a remarkable one, a bright star in your clinical diary. I welcome the nursing fraternity from India, Singapore, Bahrain, USA, UAE, Saudi Arabia, Oman, Ethiopia, and all over the world. Around 35 million people worldwide suffer from substance use disorders, while only 1 in 7 receive treatment. The reality today is that the chapter of substance use challenges the treatment and approaches available for person since COVID-19 transmission. This idea brought out the theme for this webinar. With this beginning, it's my pride privilege to introduce the very brilliant, talented personalities who will speak and may inject the current practices for substance use into our veins. Dr. Mailvahanan Veerasamy, I'm very happy to bring in a man in nursing who is none other than the first speaker, Mailvahanan Veerasamy. Sir has been connected with PhD in 2002, graduated from RVS College of Nursing, Coimbatore, and post-graduated from Savitha College of Nursing, Chennai. He has traveled from south to north of Tamil Nadu for his professional growth. And importantly, PhD in mental health nursing, also touched the field of psychology. He has built up a beautiful career growth scale starting from the designation of clinical nurse in 2003 in Ireland till now to the current position of Assistant Director of Nursing, Community Health Organization, Cherry Archer Hospital, Dublin, Ireland. He has tried with heart and soul for his professional growth through training, certification programs, presentations, and publications, and to add on many. We wish your travel as a role model for today's nursing students continues forever. Sir will be presenting on the topic epidemiological reflection. The other resource person we have here, Dr. K. Selvaraj. We have digged up to get a diamond stone with us today, who is a distinguished professor in the sphere of psychiatry named Dr. K. Selvaraj. Sir graduated from Tanjavur Medical College in 1985, post-graduated as MD in psychiatry at Topiwala North Medical College, Mumbai, completed his DPM DNB. Valigati means show the way. Sir has been a turning point in most of the clients' lives. As by the name, he founded the Valigati Mental Health Center and Research Institute at Coimbatore in 2002. His region of expertise, child psychiatry, psychotherapy, research, and teaching. The training, the awards, the presentations, the publications are magnificent, sir. He is a treasure of resources for many, including students from medicine, nursing, MSW, occupational therapy, and so on. So we are extremely amazed with the graph of your professional journey in the world of psychiatry. We wish your progress notes, both as an eminent psychiatrist and a great teacher, continues as a never-ending point. Sir will be speaking to us on the topic cognitive behavioral strategies. The other speaker we have here, Dr. Abhinav Chitra. We trapped a young genius from the field of psychiatry, Dr. Abhinav Chitra, born and brought up at CMC. I mean the professional background. Graduated from CMC, post-graduated as MD Psychiatry from CMC, and currently staying at CMC at Assistant Professor in the Department of Psychiatry. An expert at clinical psychiatry, psychopharmacology, psychotherapy, and dual diagnosis. Sir, we know you for your sincerity, dedication to the profession. Sky is the limit for the clinical spirit with which you work. We wish your progress notes with indefinite number of milestones and keep pace with such educational services towards the nursing field. Sir will be speaking to us on the topic motivational enhancement. With this introduction, I invite Dr. Mailvahanan Veerasamy to speak on the topic epidemiological reflection. Over to you, sir.
Many thanks for this invitation and organizing this wonderful live webinar, which is vitally important what is going on around us on when especially the COVID-19 a pandemic is going against the whole human being in the globe. So they asked me to focus on epidemiological reflection of substance use during COVID-19. So as they introduced me, I work as the Assistant Director of Nursing in Mental Health Department, Health Service Executive, Ireland. I'm not going to spend a lot of time to explain about my background. And just, I know the audience-wise, maybe undergraduate students, postgraduates, and doctoral degree holders, and other audiences. So I tried to give a bit of background as Dr. Salvaraj and Dr. Abhinav is focusing on specific area. So I tried to give a bit of background as introductory speech as well. So as we all know, alcohol, tobacco is the major problem in India and of course the whole world, and also other drugs involved when we talk about substance abuse, including opioid derivatives and related treatment and everything. We will follow all those things in following slides. And WHO 2019 clearly declared that a lot of violence, injuries, and mental health problems are happening because of ongoing substance abuse. The worst form of consequences is number of suicide across the globe secondary to substance abuse. So just a quick glance on etiology of substance abuse. Most of us know, in case if I have my undergraduate students, just like that of giving them a little bit of background. So as you see in this slide, family discordance, economic stress, domestic violence, poor interpersonal relationship, these are all happening as people are self-quarantining and they are isolating. So, and the social anxiety, depressive episode, post-traumatic stress disorder, these also get worse in this highly pandemic situation. When you talk about social isolation and distancing from each other for 2 meters and everything. And ultimately they get isolation. If they have depression, they are more prone to get into alcohol addiction or taking other drugs, one or another form. And also substance withdrawal. Of course, we have seen a lot of people queuing up in front of Taskmark in Tamil Nadu. I was able to watch in television, and more or less, I know the public blame them, but there could be a cause is they try to avoid the withdrawal symptom. That could be the cause why they queued up for kilometers. And of course, the teenagers seeking fun, getting high, means getting stimulation experience, and these are the common factors. Moving on to next slide, let's talk about drug abuse behavior. So as you see in the drugs, in this slide, it is dynamic. You can categorize. People get intoxication, and the next goes to more or less dependent, and then addiction, and afterwards they ended up in rehabilitation setting or in the community, making all those socio-pathology situation, which may not be pleasant environment for the community as well as for their own health and the family relationship and everything. So just to the topic, I'm trying to focus on the topic what they gave me, epidemiological reflection. So when you look at the epidemiology, just quick glance, there are three factors involved here: host, environment, agent. In my study, I'm going to focus, in my presentation, I'm going to focus on magnitude problem, dependence problem in India. Means magnitude of substance use. Document was published by Minister for Empowerment that talks all about between the age 10 and 70. They did vast survey across India, and they focused mainly on between 10 and 70 years old people. And male is predominantly alcohol, the drugs. Genetic profile. So we are going to talk about this host when as we go through these epidemiological figures and the environment, the temperature, altitude. And when I went through those documents by the government of India, around Himalayan hills, you can see people are using a lot of cannabis. And when you come down to the south, like Karnataka, Tamil Nadu, and Pondicherry, you can see alcohol taking lead rather than cannabis. In my understanding, the environment is all about the geographical structure and the availability of things. And housing, neighborhood, that also gets affected. Neighborhood could be affected because of the social distancing. And the housing, where I am talking from Ireland, is a major issue. The climate is very cold here. People live without housing. That affects, that makes them to take drugs and everything. I'll come back to that. And when you think about the agent, biologic, bacteria and viral, we are talking here about viral, our popular COVID-19, and chemical is alcohol and smoke. And of course, you can add more chemicals, what we are talking about, cannabis and opioid derivatives. So these three factors, this is the way we are going to reflect today, just looking at the various factors right now with the context of COVID-19, and we can explore further our thought process by making effective reflection, how we can help our community who has this kind of problem. So epidemiological reflection involves the prevalence, nature, and consequences of substance use to better understand patterns. So that means how it was, how many of them were taking alcohol or VI derivatives or cannabis or solvents, whatever it can be, and what is the trend now. I try to pull data together because it's very hard to get live data, what is happening in pandemic situation. But I tried my level best to pull data together to get all of us get a bit of more reflection. Trends in substance and drug use. We can talk about it from WHO data in a few minutes. So this is the graphical substance use, alcohol, caffeine, and tobacco illicit. When you talk about caffeine, more or less the whole world, 70 to 80% falls into that category. Next category, alcohol, roughly speaking, every fourth person between 10 and 70 years old is taking alcohol, according to our data, Indian statistics. Tobacco is a major problem, of course, and the illicit drugs. There's a lot of drugs are coming out nowadays. I came across few things I couldn't understand in my clinical exposure, like my team. A lot of stimulants and chemicals. After this internet culture came in, online purchasing came in. It's very hard to monitor what type of chemicals are out and available. So how serious it is? More than 3 million people died as a result of harmful use of alcohol and other substances in 2018. This represents 1 in 20 deaths. If 20 people die in the globe, 1 person dies secondary to substance abuse. More than 3/4 of these deaths were among men. Of course, the men takes more alcohol globally, and India as well. And Indian statistics says it's out of 17 people, 16 men, 1 woman across the country. Overall, the harmful use of alcohol causes more than 5% of the global disease. Of course, when you think about it, starting from type 2 diabetes, metabolism disturbances, COPD-related problem when they use solvents. So we'll look at another slide. So they create comorbid problem, high blood pressure, all those problems comes up, which makes the clinicians feel awkward to deal with and handle with. We'll talk through in next slides. Epidemiological facts and figures. So I told about 3.3 million deaths each year. So 15 years or older drinks 6.2 liters of pure alcohol per year. It is worrying statistics from WHO. Less than half the population actually drinks alcohol. This means that those who do drink consume on average 70 liters of pure alcohol annually. 38.3% is global picture. I think in India, 22 or 23% of people are drinking alcohol. Comparing with global picture, we are a little bit less, but we are not far away from the global level. As we all know, the surge of substance use is increasing, especially after COVID-19 kicked in. So 31 million persons have drug use disorders across the globe. 11 million people inject drugs, which is more complicated when you think about hepatitis C and the prevalence of substance use across globe. The United Nations International Drug Control Program has estimated nearly 141 million people has uh, has been using cannabis alone. Especially United States is getting worse. I remember reading in the newspapers and the media, some states try to legalize use of cannabis. So it's a lot of controversial thoughts are going on around the globe at the moment. Even government of Ireland here, more or less, certain things are um, legalized to use for medical purpose. But this is a very interesting topic, especially in America. You can have more reading if you're interested to know how these people are advocating cannabis to be legalized at community settings. So this is a very important slide. Magnitude of substance use in India, Ministry of Social Justice and Empowerment. After 2004, I think they managed to do vast survey. When they did in 2004, they focused the age group between 10 and 60, whereas in 2018, I think they covered for 10 to 11 months to collect the data across the globe. High amount of sample has been included. I would say statistical reliability is quite high, and they, based on that survey report, they estimated this data. So alcohol use, they say, so my understanding, just for easy understanding, 100 crores people, 100 crores as a population between the age of 10 and 70. Imagine now 16 crore is using alcohol, 3.1 crore is using cannabis, opioid use 2.3, that's nearly 13.1, 21.1, 21.4, 77. So nearly 22 or 23 crores of people are using one or other form of substances, which is, if I say 100,000 people, nearly 25%. I mean, out between the age of 10 and 70, one every fifth person or one every fourth person is using one or other form of uh, chemicals. I mean, the substance. Either could be alcohol, could be cannabis, could be opioid, an inhalant. Especially when you look at the cannabis and opioid use, this all mainly around the mountains, the main area. I think the north is predominantly taking over. Alcohol use in India, when you look at the state-wise picture, Tamil Nadu in third place. I think 37 crores or more or less, 37 lakhs are looking for rehabilitation treatment. That means they are in difficult situation, especially in this context. 37 lakhs people in Tamil Nadu have significant difficulties. Now you can understand why there is a big queue in front of alcohol shop or liquor shop or off-license shop in Tamil Nadu when the government tried to do lockdown and reopen the place and everything. It's very challenging for our community, clinical community as well. 37 lakhs people, withdrawal and all, you name it. And if they have more problem and they may have the tendency to substitute some other drinks, maybe locally made alcohol and everything, unrelated health problem. So when you look at they categorized, that survey categorized problem users and dependent users. And as you can see Here, the male and female ratio is explained at the bottom of the slide. Moving on to next one, the consequences. Of course, I a little bit covered the early part. Cardiovascular disease. The pathophysiology. I don't think I have time to go through all those things, but cardiovascular disease is quite common. Respiratory diseases, of course. When I say respiratory diseases, when people are using the solvents or inhaling stuff, smoke, and cause respiratory disease. So this is very basic things we learn from the beginning. Type 2 diabetes is secondary to metabolism disturbances, alcohol or drugs, the overeating or metabolism imbalance leads to obesity. Obesity leads to type 2 diabetes. Immune and central nervous system depression. Of course, the whole substance puts knock-on effect on central nervous system, which leads to poor sleep or imbalanced lifestyle. All these things to poor immune system, which is hugely compromising in this context of COVID-19. And of course, the depression is the major factor. It's a comorbid problem, depression and alcohol dependence. So other psychiatric disorders also can happen. Some people get schizophrenia because hallucinations can create schizophrenia-like symptoms. And usually alcohol dependent syndrome is always associated with one or other form of mental health issues. And environmental challenges, housing instability, especially like cold countries where I come from, European countries, it's a very hard 4 months we get here, snow and ice and everything. It's very hard to see people without housing. That's ongoing problem though, these are developed country. And unemployment, of course, a lot of people lost their job in this context of COVID-19, and criminal justice involvement. There is a narcotic act and everything there across the globe, but still people are well able to do drug trafficking, and the drug sales are widely going. And even the countries like here where I am living, Europe, UK, and Ireland, and all, America is you can talk about. It's a lot of issues because you all could have enjoyed watching Hollywood movies to see how this drug gang is working. It's very difficult. Even myself came across, and I have to face few issues. And when patients gets admitted, I have to take the drugs and report to the police and do the follow-up with Narcotic Control Act locally. Can be very challenging for clinician at your time as well when you deal with it. Thankfully, Tamil Nadu is a bit far away from cannabis. I hope I'm not having any scientific statistics, but I think Tamil Nadu is okay comparing with North. It's my understanding reading few materials here. And why people who use drugs are at risk during COVID-19. So as I explained earlier, high level of physical and psychological health issues. Of course, it starts from psychology. Uh, People get self-isolation, have to stay away from the family, and people wherever they travel, wherever they went, they were stuck and unable to contact. Even I remember reading the newspaper recently, some IT engineer jumped from the third floor, fourth floor in Bangalore because he was not able to go from Bangalore to Tamil Nadu, somewhere, I think Madurai, because he was not able to see his own family and children. Of course, he has technology and everything, but that gives us great insight and good reflection how important it is to go near to family or close and relatives, to stay with them, and the physical presence, how it important. So that's the big challenge for us at the moment. Asthma and COPD gets worse when people are thinking heroin and crack cocaine, because as you know, these substances get into lungs, and of course it develops related pathophysiology, which leads to asthma and COPD. And COVID-19 virus loves our respiratory tract, as we all know. So combination of asthma, COPD, and with the COVID-19, you could imagine how hard it could be for our clinician who is working in ICU with all this PPE, not even ICU, and even all the clinicians from across the globe. It's a very challenging for every one of us. And opioids such as heroin and related overdose. Say, for example, methadone management, we forced to give 1 week supply at the minimum due to transport network problem. And lack of communication. So that's sometimes what happens when they have the tendency to take overdose. That make a person to stop breathing really, and these drugs can weaken the immune system. So immune system is weak, lungs is spoiled already. The oxygen saturation may be 90 or 92, and add on to this, COVID-19 is getting into our respiratory tract. You can't even imagine how hard it can hit people who use substance abuse. And tobacco smoking and nicotine dependence are very common. Of course, this is quite common among Indian community. And adding this with COPD or asthma, plus COVID-19, so things gets more complicated. So this is the area we're supposed to reflect how we are going to handle this across not just psychiatry or psychology alone, but when you think about COVID-19 gets into the system who has a psychiatric issue like substance use disorder, and this mainly goes on biological issue, and then the clinician who works at frontline is supposed to look at these factors carefully to save the life of people. Uh, and crowded environments such as some drugs taking setting increase risk of exposure. If you forget about the drug taking setting, just Chennai itself, very populated city, at the beginning of I think it's June and all, they were not able to control the transmission of COVID-19 from, I think more or less it looked like communal transmission. Of course, the government authority denied having any communal transmission, but what happened when people redistributed across Tamil Nadu? It started calm down in Chennai, but other areas started picking up. So any crowded situation, even normal community, the COVID-19 very fast transmitting from one person to other person. Imagine now people who is under intoxication, taking drugs, and especially in Ireland, it's a very sad situation. The homeless people, I'm managing the access team. My colleagues goes out and outreach people who is living on street and dealing with them with this hard time is shocking. I can talk about that for an hour. I'm not going to get in there. The next one is the healthcare and housing, as I covered this already. And also, if they don't have housing, they don't have address. If they don't have address, they can't access the health service. That's the way the developed countries are. That put them in stigma and shame. They stay back at home. They get extremely sick, and we have to lift them from the street to hospital through ambulance. Sometimes we need to do airlifting as well, which is very sad situation. People are at risk of drug overdose from using alone in isolation. Of course, this is a major problem in a modern nuclear society, especially here in Ireland. Not the family system is valued like India, but again, a lot of people lives on the road. That makes a lot of problem, and especially it worsened the situation of them during this COVID-19. The withdrawal in isolation. Travel restriction could impact on chain of supply, as I covered in the previous slide. Say, for example, methadone treatment is quite popular here, and because of transport network problem, of course, government of Ireland is running the public transport. I would say this is the major problem in the rural area. Thankfully, in Dublin, where I am, where my service is, thankfully we are managing reasonably well because the transport network is not that much affected. The government put some restriction and still bit of travel is there. But I would say in Indian setting, it's a very challenging. Sometimes people need to travel 100 kilometers, 200 kilometers to get the treatment to meet the medical facilities. So I would say it is very vast in our setting back home in India. Um, so I'm sorry now, I tried to get accurate data, the current data from various resources. I couldn't find very effective specific data for each state. So I took one of the sample here. Punjab has 23% raise. In the March, there was only 4,14,000 people were registered for treatment. Between March and now, maybe a few weeks ago, added on 130,000. That means 1,30,000 people have signed up with since the lockdown was imposed. So just look at this picture, how badly the surge is. So 4,14,000 people added on 1,30,000 within 4 weeks. So nearly 1:4, 4 lakhs and 1 lakh, just 1 lakh people started taking substance use, just Punjab state alone, which is very small comparing with Tamil Nadu and Karnataka and Andhra Pradesh. So you can see, I can estimate this picture. When you talk about 37 lakhs people needs treatment for alcohol dependence in Tamil Nadu alone, according to 2019 statistics. But just imagine, just add on with maybe 10% in that, more or less, you're talking about another 10 lakhs added on with the Tamil Nadu population, because a lot of people are nearly on dependent category already. So they are falling into the seriously unwell category. So nearly 50 lakhs people are suffering out there, roughly speaking, by looking at this slide in Tamil Nadu alone with alcohol-related issues. But again, the action plan and all, we can talk about it in some other time. Move on to next one. Impact of COVID-19 on substance use. Of course, as we all know, even we can feel in our own pockets how it affected our economic situation and employment and our comfort, social networking, holidays, leisure, social psychological relaxation, and everything is nearly gone for the last 6 months. The whole globe is suffering. The pandemic disproportionately affects people with substance use disorder. I was reading the article there for part of preparation. One of the author wrote, a pandemic within pandemic. So more or less he tried to say from America, COVID-19 is pandemic. It's secondary to COVID-19. A lot of people started using the drugs and especially the cannabis and opioid derivatives in states. So that also getting pandemic, according to that author, which is a very valid point to note, and it is very valid word to reflect this morning for all of us, what is happening around the globe. So impact of COVID-19 substance use, the pandemic leads to environment. So I cover that one there. Socioeconomic disparities, of course, I covered that one as well there. Current addiction care practice during the COVID-19. Formulate national policies. Of course, I think Indian setting, the government published a lot of guidelines. I was able to go through them briefly, and they are trying their level best with available resources. You know, we have a lot of scarcity. Even developed country, we all think the developed country has all the facilities and everything. The whole globe is struggling. Nevertheless, of developed country or developing country, it's a major problem across the globe to uh, run the addiction service successfully like before COVID-19. So we like back home here, we are trying to do telepsychiatry and you know the lot of technical facilities available at the moment. Health service executive where I'm working here, they bought a lot of license to run the program, and then confidentiality is a big problem here in Europe and European Union. So a lot of breach of confidence, a lot of issues. Then they refined and they spend a lot of money to get these softwares to run the day-to-day things. So our clinicians, frontline clinicians, has been using and this, and also we hired few places where we can find more space, and we are trying to facilitate important group work and family meetings and everything at the moment with using adequate PPE and social distancing. So just focusing on India, pneumonia versus smoking, of course, as we covered earlier, uh, solvents and then smoking of various substances could lead to pneumonia like symptoms. And then adding on COVID-19, the things get worse and the mortality rate could be high. Morbidity goes up and then mortality goes up as well, secondary to substance use. Nationwide lockdown and access to healthcare facilities. Like what this one, some people have to travel too long, and closure of licensed liquor shops and several adverse outcomes. As I told, if you stop supplying drugs, including alcohol, for the people who is on dependent category and who is more likely to develop withdrawal symptoms, which may lead to a lot of physical complications, and also they may ended up using substitute, making their own alcohol or certain things, which leads further complications. So it's a very awkward situation across the country. No clarity regarding the running of opioid substitution. One of the author from India, he wrote it in an article from North India. He clearly wrote, senior clinician, what is the practical difficulties he has been facing with his colleagues. So I would say he is talking about methadone unrelated treatment. It's a very difficult because, as we all know, Indian geographical situation is very challenging. Concerns regarding feasibility and accessibility of telehealth. Yes, do we have internet across India? Do we have access to 4G or 5G? It's all very good in city environment, but when you think about rural population, it's highly worrying and challenging. Uh, it's very hard. Uh, and then closer rehabilitation has resulted because the direction from public health department is not to see people face to face. As a result, what happens? We were forced to close a crowded outpatient department. We have to regulate it. So as a result, people ended up waiting for a long time to see the clinician and discharging prematurely, creating the beds and everything. That's happening across the globe, not just India. Even in Ireland, we have been doing this. We have to stop seeing patients, too many patients, and the family meeting has to be rescheduled or cancelled. People ended up waiting for long delay, and which made the situation worse on some people. So we are all facing difficulties across the globe at the moment. Management strategies, of course, two doctors are going to talk and focus on those area, particularly cognitive behavioral therapy. And then I said that this is all basic things as we're always going, counseling, treatment, rehabilitation services. But the only thing is we are trying our level best to use through tele psychiatry. That means using all the technology, what is available with us to talk about these things. Non-specialized services, which provide treatment to people with substance use problem. Non-specialized service means not just because the department has to associate with other things as well, because always they come with comorbid problem. Emergency management. Of course, the government of the Department of Health in Ireland drafted all those measures, and they sent bundle and bundle of documents how to follow, what are the protocols involved. And there are a lot of voluntary organization which is associated with HSE here, and Jigsaw we call. If anyone is interested, you can Google it and see. Jigsaw is a special social agency which coordinate with us to help out these substance users in Ireland. Of course, there's a lot of NGO available in India as well. Law enforcement agencies, police, customs, forensic. It's suddenly a lot of people using drugs here in Ireland. A lot of arrest has been made. We have been getting the data from Department of Health. Number of arrests secondary to use of drugs and driving under the drug influence. That's increasing across the Europe and of course in America as well. I would say it's happening in India too, but unfortunately we do not have live statistics around this. And involvement of governmental, non-governmental, private agents should be included. Of course, we have been doing it, but it's a good reflection here is, do we have enough resources to do this? Management initiatives by WHO. Of course, it's again, it's I hope everyone knows this one. This stage is they introduce safer alcohol control initiatives to reduce the harms caused by alcohol. Their target is they are ambitious to reduce harmful use of alcohol by 10% by 2025, which is very challenging task for WHO. It was good until the COVID-19 became pandemic. Maybe it was smart goal, specific, measurable, reachable, and achievable within time frame. But I'm reflecting myself as a presenter myself. This is going to be very challenging because already surge of substance use across the globe is getting hard, hitting hard. So it is a big challenge in for WHO how they're going to achieve this target. I would say best wishes to them. As a clinical people, we can try. our level best to achieve this one. Even if they reduce 1% by 2025, I'll be thrilled to see that. Being honest, hopefully things will change. So safer, what's that mean? Strengthened restriction on alcohol availability. A stands for enforced drink driving countermeasures. F stands for facilitate access to screening, brief intervention, and treatment. So of course, the assist model, they developed the wonderful tool all clinicians are using across the globe. E enforce bans, raise prices. It's all happening already. Where I am, we have strengthened, advanced, and enforced drink driving. So I told you there are a lot of arrests made last good few months now. The stage in Ireland, access to screening, of course, we have been doing. Nevertheless, of this, COVID-19 is making them to use more substances. Enforce bans, of course, the police force and the Coast Guard. I mean, I'm living in Ireland. Coast Guard sometimes arrest people and they bring with psychiatric condition rather than taking them to the court and prison. We have to treat them before they produce them to the justice system. So we meet Coast Guard as well. Nevertheless, of all, and of course, the price is quite high. The tax is quite high across the Ireland, but still the surge rate is significantly increasing last few months. I'm sure the same thing is happening in our setting as well. So other strategies, primary care, addiction, mental health care system, screening assessment. It's more or less, I'm repeating the same thing here. The health and social care systems to provide appropriate and cost-effective health services. With these are the recommendations from magnitude of substance use in India document. So done by National Drug Dependency Treatment Center and the AIMS recommended this, all those things for Indian setting. So coming back again to Ireland, this is what we have been using and we have been telling our service users who comes with things. As you say, the slide is self-explanatory. You're the risk of serious illness from the coronavirus. Same, the basic thing, don't share the drugs, wash your hands, all those, the basic protocol. But we are very specific about the advice. What is the specific issues they get, how they can mind their mental health, and what are the available resources online. We have 24 hours helpline and everything. So we have been educating them how to do this. In Ireland during COVID-19, reopening consideration. We have been working hard. I'll be doing that now later on this morning. How to bring back all the services, which is significantly challenging. I was looking at the day support standard yesterday.
Mailvanan, sir. You are not audible, sir.
Hear me now? Hello?
No, sir.
So mine is not mute.
Okay, sir.
Is it okay now?
Now it's okay, sir. Carry on.
Okay. Sorry. So only we managed to get 25% of population can come back to the day support center, which is a very hard feeling yesterday. So what we're going to make is a bit of slot of people, maybe 10 people a day. We used to get 25 people comes to the day support center. We're thinking of getting only 10, which delays my patients who comes there every day and meet each other, and enjoy the gathering. So I can see, just as an example, live example, what I'm dealing with my colleagues is as going on. So 25 patients comes to the day support center. It's going to be only 10. So 15 people has to wait. So every day they come in and they
are not audible, sir.
Happening. Can you hear me now? Hello?
Yes, sir.
Hello?
You are audible, sir. Carry on.
Yeah?
Yes.
Sorry. Implementing process for managing and responding to COVID-19. Health and Safety Authority in Ireland produced a lot of template and document how to bring the employees back to work after this COVID-19. Being honest and proud to say, Ireland is doing very well to control this COVID-19. We had big fight with this COVID-19, especially my department where I'm working. The first cluster came to my department. Two of my colleagues ended up in ICU. Thankfully, they all recovered and they are recovering still. One of my colleagues got significant physical problem. However, the island is doing well, but the thing is, the government is quite adamant to maintain that situation. So that's what we are taking precautionary approach to reduce the services. But of course, India, it's quite saddened to see it's going beyond the limit at the moment. It's very hard to control this COVID-19. So we all need to be extraordinarily careful. And of course, as a result, it makes significant impact on service delivery across India. Conscious for alcohol use disorder treatment. So we have community mental health nurses or clinical nurse specialists. We recruited more people, redeployed people from other services to join them and task force, and they go together and reach the people and do the home visit rather than they are coming out. They are vulnerable people if they come out. Their risk of not following the social distancing advice might potential to transmit COVID-19 to other people. So we have been doing outreach program. So my colleagues goes out and see them in their home rather than they come out and see, because as a clinical people, we can use all this PPE to avoid contamination or transmission in the community. Alcohol withdrawal management, of course, my colleagues, the pharmacy, we have a head of the department meeting more or less every week now, including chief pharmacist. So we all sit together and try to make alcohol addiction area is one part for my area. I don't do fully in charge for this area, but my colleagues cover this particular department, the addiction department. Telehealth, I told you before how we have been handling and how we are using the software. And prescription and refills, they changed the protocol here. Maybe the email, e-prescription, it came up and they developed the thanks for the technology. We can do online now. That's being approved by Medical Council. And of course, the advanced nurse practitioners and clinical nurse specialists are helping the medics significantly in this COVID-19 here. My colleagues who has a nurse prescription codes, they have been doing extended role and doing the prescription as record because they can go home and assess the person and they can do the prescription because clinicians are very busy in the hospital setting dealing with this challenging COVID-19 time. Conditions for high-risk patients, of course, in my settings where I'm in charge for 60 residents who live in hostels, we call them. And we sat together with all the clinicians, all the MDT. We categorize the people high, medium, low risk. High risk means people who use drugs and the comorbid illness, lungs issues, and any other physical problem like comorbid type diabetes or hypertension. We categorize high. And we developed the protocol and algorithm in case if they get COVID-19, how to deal with it. And of course, a lot of guidelines are available on the website of Health and Safety Authority. We have been incorporating those things and we are ready, because just to get ready all the documents together, one A4 sheet summary of the person, because COVID-19 can significantly damage the person within 24 hours, even 48 hours in case if they have comorbid and serious physical health problem. So we prepared. And if anything happens, we can proactively act on it, and then we can transfer them to a general hospital. Providers and programs should continue to implement policies and procedures to reduce risk of this is politicians and other people area not going to focus on those strategic stuff. So I'm trying to share my practical experience, what I have been facing last few months with my colleagues to deal with this situation. So I'm nearly getting only 2 more slides to go. I won't be long. How can substance abuse be handled during the pandemic situation in India? When I went through a lot of documents, There is a recommendation of reframe the public health policy according to Indian context. Need to open telecounseling support services. I'm not sure how far these are established in our setting back home in India. People-oriented healthcare services, that's very challenging as well. Collaborate with voluntary organizations, very, very important. As we all know, government, both central and state governments, we do not have enough resources. The medics and all nursing colleagues are struggling a lot at the moment. In fairness to government, they are trying their level best to support, but a lack of resources and scarcity, which is challenging situation. So voluntary organization is very important. They play a vital role in our Indian setting. Access to outpatient service and essential medicines. Of course, this is again a responsibility of government, Department of Health, making sure that they are facilitating the service to the patients to reach and availability of medicines. Controlling the inflation of the cost of medicine. Of course, as we all know, when the demand increase, supplies go down, and they make induced demand in market. That's quite popular in Indian settings. I would say they will try to do for medicine as well. That has to be regulated to make sure that in this crisis time, people are able to get medicines and it is cost effective for them. Improving the two-way communication between people and the government healthcare agency. I hope that's happening. I'm sure last 25 years, 30 years, significantly things are improved in Indian setting. Controlling measures to minimize the psychosocial stresses. Of course, the social networking, I know the mobile network is good, but still not is going to replace face-to-face meeting or meeting each other, greeting each other in one place. That's a significant challenge for all of us, especially alcohol anonymous, narcotic anonymous group. I'm not sure how far we are doing back home. We have to forcefully, we have to stop here, and we reduce the number of people who participate in that group as well. So that's a good context to reflect on this topic. Utilizing private and corporate healthcare agency towards the pandemic service. Of course, when you talk about corporate healthcare agency, my understanding is this is the health insurance crowd, and how well they are helping the community at this crisis situation across the globe, and especially in India. So what is the take-home message? So United Nations Secretary clearly said, don't ignore treatment of your mental health during COVID-19. That's nothing but psychosocial stresses. At the early stage, try to get proper advice from clinicians. His own word, Ian Secretary, what the world needs now is solidarity. With solidarity, we can defeat the virus and build a better world. And then World Health Organization, coping with stress during the COVID-19. As I told you in my third slide, I think the second slide, how the causes, what are the causes, how we develop into stress and then get into this addiction habits, especially it is more vulnerable during this isolation period. So that slide talks about how to cope with stress. It's recommended by WHO. 10 practical tips for supporting mental health during COVID-19. That's Mental Health Ireland published this poster. So acknowledge your concerns together. Brainstorm the things you are doing well together. Chat to your loved one about their needs and your own. Do up or review your crisis plan. Ensure you have important numbers, one safe place. Find, because that's for the people who is unwell. That's what I was talking about earlier on. Our patients who lives in the community, we prepared and we categorize them high, medium, and low, and all the numbers, next of kin, close contact, and everything, because the things are happening rapidly, death and everything. So we prepared that to document already. Find and add the numbers to give this list useful. Yeah, that's all the social services, tele services, 24 hours helpline, ambulance number, urgent A&E, external emergency contact number locally based on their catchment area in case if they struck and not able to think properly. And the mental health team call, we have been, we developed poster with the social work department, and every resident got the letter by post all this basic information. Nearly, I think they made 4 or 5 page document. We circulated that. Have you chat with some friends and neighbors? Of course, that's a social networking. Identify supports to help with shopping, pharmacy if needed. Because, say, for example, some of our patients cannot understand, they cannot process the information of public health recommendations. So we have to appoint the advocate from the voluntary agencies to do shopping and everything for them. My community mental nurses are coordinating with them to organize that type of things to avoid communal transmission. Just know that you can do this and you are not alone. That's a positive message from Mental Health Ireland document. So this is all the information we have. We need to think of when you talk about epidemiological reflection, what is going on at the moment. And thank you very much. I know I meant to take only 45 minutes, but I took a little bit extra. My apologies for the organizers and other 2 doctors who is very busy in their clinical schedule. Many thanks for listening. Thank you.
Thank you, sir. It has been an excellent deliberation of the statistical information which have given on a global scale and from India. All informations, I feel the participants would have gained to their side. This particular statement which we have from the state of Tamil Nadu is alarming, like it's a recent information which is available during the last week. After the lockdown release, 190 crores have been generated from the Tasmac shops. I hope your presentation linked with this data has created an awareness, and we are in the stage of offering a help and support to this particular category of clients. There is a question from the participant side, sir. I hope your presentation has answered her from Nirmala Nanathurai, madam. How far has nurse entrepreneur you can prevent strategies are available in Ireland? I hope this question.
Sorry.
Yeah, thank you, sir. Thank you for having connected to our webinar. And we have a great person for us today to speak on cognitive behavioral strategies. I welcome Dr. Raj to take over the session. Sir, you can go ahead, sir. Yes, sir, you can go ahead, sir.
Yeah. Good morning. Shall I start?
Yes, sir. Good morning, sir.
Good morning. Respected Chairperson Dr. Jayasudha, fellow speakers Dr. Mail Vahanan and Dr. Abhinav, and friends and students in the audience. A very good morning. Dr. Mail Vahanan has given epidemiological reflections. This COVID-19 situation has increased the need for help for substance use disorders and addictions. People having more withdrawals, and where available, people are taking a lot of substances and alcohol because they don't have much to do, and the healthcare system is taxed with people with withdrawal and severe addictions. Now we will go into the treatment strategies, and the next 30 minutes I am planning to give a broad outline. We'll touch upon the history of the de-addiction treatment and introduce the principles of cognitive behavioral therapy, a broad outline, and some specific strategies in addictions and some practical aspects. I use the word addictions because using the word substance use disorder every time is going to be cumbersome. History of addiction treatment. Actually, we all know Tirulur, our sage, has even talked about Kallunnamai. It has been there ever since mankind was there. However, it was a social evil rather than a disorder. Only in 1700s, the concept of alcoholism as a disease was entertained. In 1984, Benjamin Russ, a doctor, uh, first argued that alcoholism is a disease and should be treated. From then on, from the Western countries, de-addiction treatment were progressing. In 1800s, the treatment was just lodging homes. People were kept up in asylum kind of homes, and only in 1900s, uh, the real seriousness came in for treatment. First New York City Substance Abuse Hospital was started in 1901, and Alcoholic Anonymous was formed in 1935, and disulfiram and other drugs are used to treat alcoholism in 1948 to 1950. So only from then onwards, the scientific treatment uh, started progressing. The evolution of addiction treatment goes as follows. As I said, initially it was custodial homes. Later, medications were hoped to cure addictions. But later they realized drugs are not going to help. So they need psychosocial interventions, and behavioral therapy came into the picture. But after some decades, they realized that limitations of behavioral management alone. They then started focusing on the thinking process, and that is how cognitive therapy became important. Later, both the cognitive therapy and behavioral therapy got merged into cognitive behavioral therapy, which is one of the powerful management strategy for addiction treatment. Of late, what we call third wave treatments, mindfulness and acceptance and commitment therapies are all coming into the picture for the treatment of addictions. Well, we are going to uh, talk only about CBT. What is CBT? Cognitive behavior therapy. It is a form of talk therapy, a method of psychotherapy. Well, we are all familiar with psychotherapy. Well, this slide uh, is the essence of cognitive behavior therapy. If you see, um, which addresses the cognitive behavior therapy, the behavior, thoughts, and feelings. They are all interconnected. They influence each other in multiple ways. These three are influenced by our core beliefs, which is about ourself and about other people and about our future. Majority of the clinical situation can be brought into these areas. There can be behavioral problems, thought problems, feelings problems, and it may be emanating from perception about self, others, and worries about the future. This model, Aaron T. Beck's model, evolved over a period of time, though it initially started only for depression. Now it is being used for addictions as well with the modifications. Uh, CBT used in addiction treatment uh, in a way to provide a model of care, and it teaches people with addiction about how to go about dealing with their addiction problem. It encourages them, supports them. More importantly, CBT provides skills to gain abstinence from drugs in reducing their drug use as well. Now, the basic concept of CBT is addiction is a learned behavior. No, that's the essence, and it can be unlearned. So that is the premise on which the whole CBT treatment unfolds. Addictive behavior is learned through a set of behavioral psychological principles, and using our understanding of these phenomena, we can treat addictions. The basic concept of CBT addictions are the learning and conditioning principles involved in CBT are classical conditioning, operant conditioning, and modeling. These three components we are going to address in the next few minutes. Basically, uh, these principles, how they contribute to development of addictions, and as well as how these principles can be used for the treatment of addictions. Let's talk about classical conditioning. Uh, well, we all know about a Pavlov experiment involving dog. A dog usually salivates when it sees the bone of food. A bell doesn't really make any difference to it, but whenever the bell is rung, then the food is delivered. There is an association between the food and the bell. After some time, by the mere ringing of bell, the dog, in anticipation of food, salivates. This is learning by association. This is a very important phenomena that happens during the development of addictions. Repeated pairing of particular events, emotional states, or cues with the substance use can produce craving for that substance. Over time, drug or alcohol use is paired with cues such as money, particular such places, people, time of the day, and emotions. Eventually, exposure to cues alone produce drug or alcohol craving or urges that are often followed by substance use. Well, understanding and identifying the triggers, that is the cues that have been conditions, is a major dimension of it. And related to that is understanding how and why our drug craving occurs. Whenever there is a trigger for substance use which has been conditioned, it elicits drug craving in the person. So we have to uh, teach the individual to learn strategies to avoid exposure to the triggers. Once a trigger happens, then it is a big challenge. Even then, it is not uh, always avoidable. But once they have got exposed and the craving happens because of the triggers, they should learn to cope with it. And they should be able to reduce the craving or even eliminate the craving so that they can protect themselves from going back to substance use or alcohol. Well, that is about classic conditioning. The operant conditioning is another form of learning. Uh, this is can be simply understood as rewards and punishment. Uh, Drug use is a behavior. This is reinforced or encouraged by the positive effects that occurs from the pharmacological properties of the drug. Somebody smokes a cigarette, he gets a kind of relaxation. Somebody takes an alcohol, they get a kick and a pleasure out of it. It automatically increases that drug use behavior. That is reinforcement. Negative reinforcement also happens uh, while drug and alcohol use. While somebody has been habituated with uh, substance or alcohol use, after some time, when they stop taking alcohol, they experience a lot of withdrawal symptoms. This unpleasant withdrawal symptoms uh, is relieved by taking the drugs. So, in order to uh, escape from the suffering and the unpleasantness, they end up using the substance. This phenomena is called negative reinforcement. This is also a very common, powerful factor operates during the later part of addiction. Positive reinforcement strengthens a particular behavior, that is drug taking behavior. Pleasurable effects from the pharmacology of the drug enhances drug taking behavior. This happens in the early part of uh, addiction career. And peer acceptance obviously encourages the person to go for taking drugs and alcohol. uh, any reinforcement increases the uh, behavior. Any punishment decreases the frequency of behavior. These both operate based on the operant conditioning principles. Well, this operant conditioning principle is very useful in functional analysis. That is, to identify the high risk situations uh, for drug and substance use and determine what are the reinforcing factors. Uh, these consequences to drug and alcohol related behavior, we have to evaluate the long term and short term consequences so that we will be able to uh, identify the reinforcers and deal with them. And to do that, uh, we can schedule time and use the price to reinforce, and thereby we can modify the frequency of the behavior. So we are, as per operant conditioning principle, drugs and uh, alcohol are used for pleasure. But if we can develop a meaningful alternative for pleasure and relaxation, we can deal with the drug and alcohol use. Well, another important uh, behavioral psychological principle is modeling. Modeling is to imitate someone or follow the example. Modeling is a process in which one person observes the behavior of another person and subsequently copies the behavior. Well, we know about models and modeling, which is a common word used in the society. Young children are easily affected by this modeling effect. They experiment with cigarettes almost entirely because they are modeling adult behavior. Teenagers start with the cigarette because they start believing that it is an adult like behavior and they model their cigarette smoking adults. During adolescence, modeling is often the major element in how peer drug use can promote initiation into drug experimentation. It is the friends who are doing, they will imitate and model their friends. But it can be used for therapy as well. Clients learns new behaviors through role plays, and one important uh, skill they can learn through modeling is a drug refusal skill. Watching clinician model new strategies is a very powerful method of teaching, and those uh, skills can be practiced as a very important strategy to manage drug use behavior. Okay, the very important strategies are in the early stages of CBT treatment, the behavioral focus is more. The strategy stress on behavioral change. To that end, uh, the time to engage in non-drug related behavior is focused, and avoiding or leaving a drug use situation is of paramount importance. The more a person goes closer to a usual place they use drug, it is a high risk situation. So, in order to manage that, there will be a planned schedule of low risk activities, which we will use calendars and schedule those low risk activities as a competition with uh, high risk activities like drug abuse. And they should be able to identify the high risk situations also, thereby they can avoid, particularly meeting friends in the evening in a common place where it is located near a bar is a high risk situation which needs to be avoided. However, avoidance is not always possible. So they should learn to cope with the situations when exposed using coping skills. Coping skills more using coping skills more effectively with a range of problems is important. Many problematic behaviors can be dealt with the developing the specific coping skills. As CBT treatment continues into the later phase of recovery, after the patient is engaged, the more emphasis is given to the cognitive part of CBT, teaching clients knowledge about addiction and make them become aware of the conditioning, triggers, and craving. All these things will give them a better understanding of what they are suffering from, how they can cope with it. And cognitive skills like thought stopping and urge surfing can be very well taught. Eventually, once they are well into the recovery phase, uh, we will focus on relapse prevention, which is a common occurrence in addictive disorders. Well, now we are going to attend few areas, specific areas, uh, which is used in the management of uh, addictive disorders. Uh, we can call it a strategy and techniques. In the assessment, functional analysis is a very important technique, and this can be simply stated as 5 Ws. One of the first tasks in conducting CBT is to learn the details of a client's drug use. It is critical to know how the drug use is connected with other aspects of a client's life. The 5 Ws are at the core of functional analysis. The 5 Ws of a person's drug use uh, can be elicited using these questions: when, where, why, with whom, what happened. So, when do they use the drug and alcohol frequently? What time? What situation? Which place? From where they procure the drugs? And in what kind of situations they start using? What are the external triggers? And what are the internal triggers? And what is the frequent trigger for craving? And whether they are drinking alone or using it with the friends with whom they use it frequently. All these things can be elicited to give a clear understanding. And eventually, after the drug use, what happened, whether it was a pleasurable experience that makes them to go back and again, was there any adverse consequences which happened, but they are uh, minimizing the importance of it. All this needs to be uh, looked into in the functional analysis of their drug use behavior. So the questions like what was going on before you used, uh, how you were feeling before you used, uh, all this will give a clue about the triggers and what provoked the craving, and where they obtained drugs and with whom they used drugs, what happened after they used, will give a clear understanding which are essential for planning the treatment. Well, it is a very objective, structured way of eliciting that information. We can see that in the first column, the analyzes the antecedent situation. Uh, where was the person? Who was with that person? And what actually was happening? Whether they were chit chatting without any work, or was there any conflict? And during those situations, what was the thought process that was going through? What kind of feelings and sensations the person was experiencing? And it led to what kind of behavior? What did I do? And what did I use? How much I take? And what are the other paraphernalia that I used? All these things can be elicited in this. And eventually, after the drug use, what happened after that? What was the feeling? And how did the other people react? Was there any unforeseen consequences like accidents and legal consequences? All this can be elicited in the functional analysis. Well, the real value of functional analysis is finding out the triggers and the craving that is elicited in the patient. And these are all the very important strategies in management of substance use. One of the most important purpose of this 5Ws exercise is to learn about the people, places, things, times, and emotional states that have become associated with drug use for your client. These are referred to as triggers. These are all conditioned cues which they have developed over a period of months and years because of repeated use of substance use. Yeah. One sec. Hello. Sorry for the interruption. I got the feedback that the volume is not adequate. Uh, I wonder whether it's any better. Yeah. Um, a trigger is a thing or event or a time period that has been associated with drug use in the past. Triggers can include people, places, things, time periods, and emotional state. It can be external or it can be an internal trigger in the form of emotional states like anger, boredom, depression, anxiety. Triggers can stimulate thoughts of drug use and cravings for drugs. So they end up using the drugs. External triggers can be the people, the friends with whom the person has been taking drugs, or it can be the persons who sells and pushes, drug dealers. Yeah, the particular places get conditioned with our drug use, and automatically we start experiencing the craving, like bars and a particular person's house and parts of the town. Many times people go out along with their friends to a particular park or some outside place. So when they even go to that spot, automatically the craving they start experiencing. The things like money, whenever they see money, the immediate thought goes to about purchasing the substance. And even going to a movie or a dinner, it gets associated with alcohol use. And particular Time period also contribute to the triggers and craving, particularly holidays, evening time, even when there is money, and whenever there is stress, hard working, demanding situation. All this can create a trigger for craving and subsequent use. Internal triggers are commonly emotions, anxiety, anger, frustration, sexual arousal, excitement, boredom, fatigue, and happiness. Any of this can trigger craving. Well, um, these triggers and experience of craving happens in the high risk situations, and if we avoid those high risk situations, we are likely to protect ourselves from use of drugs. So, choosing a low risk situation is a very important strategy in managing addictive disorders. Situations that involve triggers and have been highly associated with drug use are referred to as high risk situations. Places, people, situations that have never been associated with drug use are referred to as low risk situation. An important CBT concept is to teach clients to decrease their time in high risk situation, not spending time with friends outing, or increase their time in low risk situation like with the family members at home or with the friends who do not use substance. Well, uh, apart from avoidance, uh, we have to have coping skills to manage a high risk situation. And because it may not be always possible for anyone to avoid the high risk situation, so they need to have coping skills and strategies when they are faced with high risk situations. Uh, well, any high risk situation can cause craving. A craving is an intense desire for the substance, and it brings in an urgency to go for the drug. Many people describe craving as similar to a hunger for food or thirst for water. It's a combination of thoughts and feelings. There is a powerful physiological component to craving that makes it very powerful, even very difficult to resist. Once the craving is experienced, it's a big challenge for the substance user to fight with it, struggle with it. Cravings or urges are experienced in a variety of ways by different clients. For some, the experience is primarily somatic. For example, I just get a feeling in my stomach, churning in my stomach. My I have palpitation. Uh, I feel an excitement. All these are somatic. For some people, it is mental. Craving is experienced more cognitively. For example, an urge to consume it now. I can't be at peace without taking that drug. I cannot take out that thought from my head. I have a strong urge to go for it. So it's a cognitive experience. So a craving can be experienced both ways. Many clients believe that once they begin to crave drugs, it is inevitable that they will use it. But it is not necessary. In their experience, they always give in to cravings as soon as it begins and use drugs. Instead, they can resist craving using some techniques and uh, developing some mastery in managing craving. In CBT, clients are given techniques to resist craving. A very, very simple technique is which is taught is 4 Ds. The 4 Ds are one is delay. Whenever there is a craving, delay uh, uh, delay yourself to going to drugs, or take a deep breath and deep breathing will uh, bring down emotional excitement. Sometimes just plain drinking water can reduce the craving, or even going for food can uh, affect the craving, and distracting oneself in that situation again can reduce the craving. So these kind of skills and techniques can help them to manage craving, and they need not always go to uh, addictive substances just because they experience craving. So it can be managed uh, by using a daily record of urges to drink, commonly used in alcohol. So you'll have a record of date, time, the situation. It can be including anything about the situation, your thoughts, feelings, whichever that triggers the urge to drink. And it can be varying. Suppose you see one friend in a temple, uh, your craving will be lower. But when you see the same friend near a bar in a remote place with money, you may have a higher intensity of craving. So that also needs to be documented. And what coping behavior was used? Use this column to note how you attempted to cope with that urge to drink. If it seems like it would help, note the effectiveness of your coping strategy. By this kind of a daily record of triggers and the craving experience, one can chart out uh, what is the common trigger, and where do they frequently experience craving, and what strategies are going to help them. So that can help them in planning the treatment. So this is a daily record of urges to drink that has been used. It is about the date. This is about the situation. The intensity has been varying. In the scale of 1 to 100, it is 75 at one place, and on a payday, it is 68. And what coping behavior was used? When they look at and analyze this data, they will evolve better coping strategies. Coping with craving. Uh, Particularly, the more and more they engage in non drug related activity, uh, the situation uh, causing craving is reduced. And whenever they experience craving, they can talk about it and discuss that with a friend, or they can use techniques like thought stopping, and of course, they can come to a counselor, uh, or they can, even if they are religiously inclined, they can pray. Thereby, the craving can be managed. Well, in spite of all the efforts by a person, the environment can be so powerful. Particularly, the peer group, friends will start offering the drugs and substances, and one should develop drug refusal skills. It may not be easy to give away certain close friends who are using drugs, but still one can uh, protect himself uh, from using drugs by using the drug refusal skills, how to say no to drugs and alcohol. One of the most common relapse situation is when a client is offered by a friend or a dealer. Many find that they don't know how to say no. Frequently, their ineffective manner of dealing with this situation can result in use of drugs. So, a drug refusal skill is a very critical element in social situation. Even when they are motivated, the friends can come together and force them to accept drugs, and they should have enough assertiveness to say no. Improving refusal skills or assertiveness. There are several basic principles in effective refusal of drugs. They have to quickly respond rather than hesitating to say no. And they should have a good eye contact and respond with a clear and firm no. that does not leave any doubt in the minds of the listener. And it has to be a brief conversation. And if they continue to insist on using drug, they should leave the situation. So these drug refusal skills, once practiced for a couple of times, they will feel more confident and comfortable. After reviewing the basic refusal skills, clients should practice them through role playing. Problems in assertive refusal should be identified and discussed. Pick an actual situation that occurred recently for a client and that can be uh, used in role play. Ask clients to provide some background on the target persons who are particularly forcing them to consider drug use. Well, people give up drugs and alcohol and they remain sober for weeks and months, sometimes years. However, it is not first time they went for treatment and they are completely free from drug use continuously from the first attempt. They frequently relapse. This happens as a norm, as a routine rather than an exception. And whenever they relapse from abstinence, there can be a lot of confusion. Uh, that is called abstinence violation effect. That also need to be dealt, uh, and CBT has got very good techniques. If a client slips and uses drugs after a period of abstinence, one of the two things can happen. He or she could think, I made a mistake now, and now I need to work harder at getting sober. So I have to put extra effort to remain sober. I have to be all the more careful. That may be one way of thinking. Or that person can think just because they used it again, this is a hopeless situation. I will never get sober. I might as well keep using the drug. So after one lapse, they feel hopeless and they start using more and more of the drug, which is not warranted. This thinking is called abstinence violation syndrome, which is detrimental to the treatment program. Uh, Most of the time, they think one lapse means a total failure. I may as well keep using it. I am responsible for all bad things. I am hopeless and I will always remain a drunkard. I don't have willpower. I have lost control. I am physically addicted. So I can't really escape from it. All these kind of negative thoughts can be happening in their mind. But clients need to know that if they slip and use drugs, it does not mean that they will return to full-time addiction. They can, that thought process can be reframed. The clinician can help them to reframe the drug use event and prevent a lapse in abstinence from turning into a full-blown addiction. For example, one person saying, I used last night the drug again, but I had been sober for 30 days before. So, a way to look at it is out of the 31 days, I have been sober for 30 days. That has to be the focus, and rather than uh, you know using it to one day, one lapse. And if they look back their long use of drugs, 30 days is a good effort considering their long term use of over the 10 years. So that is how we reframe that lapses and prevent it from becoming a full blown reuse. Well, uh, if we say a single statement, de-addiction or escaping from addictive behaviors means it is a lifestyle change because the substance gets uh, integrated into the life of that individual. Many clients have poor or non-existent repertoire of drug-free activities. All they have is work, then they go back to drug use, and very little they do other than drug use, particularly when they are moderate to moderate and severe addiction. Efforts to shape and reinforce attempts to try new behaviors or return to previous non-drug related behavior is part of CBT. The important lifestyle management uh, includes some specific skills, particularly anger management skills. Many clients go to substance use when they have strong emotions like anger. Clients are taught about the warning signs of anger, both external and internal signs, so they can identify them early and manage. Skills for managing anger includes the use of calm down phrases, identifying aspects of situation that are provoking anger, and considering options that might help to resolve the situation. Yeah, they should develop relaxation skills. Uh, uh, that is, Jacobson progressive muscle relaxation technique can be taught to them so that they will be able to understand the tensed state and relaxed state. In addition to relaxation, they can be taught slow breathing and use of calming imagery to relax themselves. These skills are practiced and acquired. Clients can be taught to apply them in various situations, particularly when they are stressful. Problem solving. It's a very important skill. It provides means of coping if clients unavoidably enter a difficult situation for which they have no apparent coping response that is immediately available to them. The problem solving skills include various steps, problem recognition, and components of the problem, and what possible solutions, brainstorming the potential solutions with others, selecting the most promising approach, trying it out, and assessing its effectiveness, and refining the plan if necessary. It's a systematic way of approaching any problem. Once they practice this skill, any unexpected situation, the client will feel confident to cope with. Criticism is a very important uh, experience in persons using addictive substances. Criticism, whether giving it or receiving it, can be high risk situation since it is often leads to anger and subsequent drug use. This is even more the case when receiving criticism about drinking or drug use. Clients are taught to calm down first, to state the criticism in terms of their own feelings, to use a firm and clear tone of voice, but not an angry one, to criticize specific behaviors and repeat and request a behavioral change, and to be willing to work out a compromise. Most of the time, whenever there is a comments or criticism about a person's drug use behavior, they become defensive or counterattack. To ask other person to clarify the content and purpose of the criticism, to find something in the criticism to agree with, and to work towards formulating a compromise. In this way, criticism may be transformed into a potentially constructive communication. Well, a brief few words about a CBT session. A session lasts generally about 60 minutes. It's a highly structured session, and therapist is very active. That 60-minute session can be divided into three parts, each 20 minutes. And during the therapy session, and empathy and acceptance should be balanced with firm teaching and coaching. So in the first 20 minutes, uh, there has to be an agenda for the session that has to be set, and we have to evaluate what has happened in the past week with regard to current uh, patient's life, and particularly what were the problems in the social area, in the environment, in the workplace, in their physical health or emotional health, and how they were functioning, and how much they were using the substance, and what kind of a high risk situation they faced. All this will be uh, assessed. And if there has been a homework assignment, whether they practiced it and what was the outcome. All this will be assessed in the first 20 minutes. In the next 20 minutes, a specific topic will be introduced and it will be discussed. And that topic and the theme will be correlated with the patient's current situation, and they will even practice the skills which are learned during that. And during the final 20 minutes, there will be rechecking on the understanding of the patient on the topic, and there will be practice exercise given for the next week, and and a discussion about what potential problem they may anticipate during this coming week. All this can be addressed. So there will be about 12 sessions in any serious attempt to give CBT to a persons with addictive disorder, and each session have a specific theme. And after 5 6 sessions, and there can be few sessions which there can be a topic of interest to patient. They can choose topic, and there will be a termination and the follow up. Okay. Uh, there are some important principles for CBT. I will just touch upon. I think the time is catching up. It has to be highly individualized. Each client is different. So depending upon the patient profile, we have to match our content of the treatment, including the examples and the homework assignments. Anything that we teach needs repetition, and several attempts have to be made uh, for learning the skills. And repetition is essential because of the drug use difficulties. They may be inattentive, their memory may be weak, and uh, particularly about the triggers, they should be constantly repeated. Even a whole session can be repeated if the patient is not picking up the skills. Practice makes things perfect. Any skill requires practice. And whenever they practice anything, there will be mistakes, and they should learn from the mistakes. And they continue to master the skill by trying it again and again. Monitoring is a very important component in behavior therapy and cognitive behavior therapy. We should monitor by getting the information and checking on the task completion that was given to them last week. And we should discuss the client's experience with a task so that the problems can be addressed in the session. Of course, uh, appreciating the client for their effort is a very, very important strategy from the clinician. Even small attempt, even small success to be celebrated and appreciated. There will be resistance on the part of the um, client to take up practice and homework assignments. So that needs to be attended to and evaluated. Many times they may feel hopeless. Do you think, is it going to really help me? They may not even try their practicing of coping skills. So that has to be discussed, and they should be encouraged to practice that. So it's a brief presentation giving an idea about CBT. Uh, CBT is often rated as the most effective approach to treatment, and it is well accepted and well received by clients nowadays. There has been a lot of refinement. Furthermore, the benefits of CBT may extend beyond the treatment period and protect against relapse. Medications have limitation in those areas, whereas CBT alters the lifestyle and they develop many skills which are useful to them in the day-to-day life. Thus, CBT forms an important tool of intervention and occupies an important place in the psychosocial treatment of substance use disorders. Thank you. Yeah, uh, there have been few questions. Can CBT be given for a group of people? Of course, there is a model group CBT, and it is a standard format available, and we have to choose the clients in an appropriate manner. And particularly in a COVID situation, being close physically is going to be problematic. Like we do now as a Zoom session, the groups of people can be brought in through this tele media that can be considered. Um, uh, and also now there are a lot of safety precautions are being um, taught even in our center. Now we conduct group psychoeducation classes with adequate spacing among clients, so it is still possible. What preparation should be done while providing CBT? Of course, a clear understanding of the patient's condition is fundamental, and a person should be familiar with the CBT principles, and they should have skills. Uh, Unfortunately, uh, the learning opportunities are very few, and it is still reach a desirable level. If somebody has got a reasonable skill in CBT, they can very well go ahead with treating with CBT. Something is better than nothing. How to help female young girls out of the substance use in India? Very challenging. Uh, Once in the past, addiction was only a male phenomena. It is no more. Uh, Even women smoke, women take alcohol, they use hard substances. Uh, in fact, there are special needs for adolescents when it comes to drug use, peer group acceptance, and a high level of impulsivity, uh, limited skills, life skills they have developed, and their dependent nature on the family. So that makes it more challenging than treating an adult. Uh, there are specific strategies which can be used in adolescence. Those strategies can be tried. Could you tell us about uh, urge surfing? Yeah. Well, many times we are not aware of our own urges and craving. Being aware, increasing the self-awareness is very important. Many times we are neglect and ignore, and we don't focus on it, only to be suddenly surprised that we are onto drugs. So being highly self-aware of what is happening is important component in the treatment of addictive disorders. Uh, with that, I complete my presentation. Thank you for your.
Presentation, sir. A child learns from parents. Truly, we have learned in a crispy manner from you, sir. We are really grateful for giving your valuable time. Thank you, sir.
Okay, you are welcome.
Now I welcome Dr. Abhinav to take over the session.
Yeah. Good morning to everybody. Are my slides visible right now?
Visible, sir.
Then I'll start. Thanks, Dr. Selvraj. That was a really comprehensive and nice talk. And truly, actually, I'm quite intimidated to go after someone as senior as you. My talk is actually perhaps a few steps before what Dr. Selvraj was talking about, in the sense that we're going to talk about a technique for motivational enhancement, which is called motivational interviewing. So strategies like cognitive behavioral therapy and CBT are really only going to be applicable once the person that you are trying to apply these therapies to is willing, is ready, willing, and able to do the strategies you're suggesting to them. So motivational interviewing is actually one step before that, about how to build up the motivation in them to change. Most people who are dependent on substances, when you ask them in detail about substance use, are ambivalent. Most of them don't come out with only positive feelings towards the substance. Most of them in their mind are also increasingly concerned about their substance use, though that does not reflect in their behavior. So what I'm going to be covering today are the essential 4 questions about this technique of motivational interviewing, which is what is it, how do we do it, when is it, when are what strategies used, and why should we bother to know about this. So we've just had one introduction talk about a type of therapy called CBT. Every type of therapy has its own characteristics, its own stances that the person doing the therapy, the therapist, assumes, and its own way of dealing with the problems that are put ahead of you. So these are some of the points that characterize motivational interviewing as a technique. So this technique is directive. What this means is that unlike what many of us think of as classic therapy in our head when we think about Freud or Freudian therapy, where the therapist is mostly only silent, the client talks with very little feedback coming in from the therapist. This technique is not like that. The therapist assumes control of the session and can direct it at various points. It's a client-centered technique, which means that there isn't a uniform format that is followed by every single individual. It has to be tailored to that individual, their personality, their context. The main target here in motivational interviewing is to try to elicit change in behavior. That's the main focus of what we're looking at here. And like I said, most people with substance dependence, when you actually probe in, will come out with some amount of ambivalence. They are not sure. Do they really want to go ahead on this? There is a conflict within them. They've not made up their mind often, and it is about, if this ambivalence is not present, to develop this ambivalence. If it is present, to help them resolve it in the direction of change. That is the target for this technique. These are very important points if one has to understand how motivational interviewing is different from many techniques. And I think the strength of motivational interviewing is that if done properly, the client and the person who has substance dependence does not feel that change is being imposed on them. We get from them all the points. So you don't, there is the big difference between giving education to the patient and motivational interviewing. So if I am doing motivational interviewing to someone with alcohol, that doesn't mean that I will start off immediately telling them all the ways that alcohol is bad for them. It means that I will ask them, what do they think? Do they think alcohol has bad effects? What effects do they think that it has? So by that's what I mean when we say that motivation is elicited from the client and we don't give them the answers. We try to get the answers from them. Generally, even if you think about yourself, if there are patterns of behavior that are solid in you and that have been persistent for a long time, it's not easy to change those patterns of behavior. Usually, a direct assault from a stranger, which is finally what you are when you're dealing with these clients, a direct frontal assault on their patterns of behavior usually ends up in the client avoiding you and not coming back to you, and the entire talk of change ending right there. So directly persuading is not what we're aiming for in motivation interviewing. Like I said, we're aiming to get things from the person and to help them realize that they somewhere or the other already know that this habit is bad for them, that this habit is harming them. giving them more negative effects by now. That doesn't mean that the person who is doing motivational interviewing, the therapist, has to be silent all the time. Though, yes, we ask a lot of open ended questions and try to get a lot of answers back rather than providing the answer. We can step into the session and change its direction if we feel that it's not going the way we would like it to go. So, we have to understand that people are complex, motivation keeps changing. Um, the first thing to realize is that change is difficult. These people have come to you because change is difficult and they were unable to do it themselves. The motivation to do any difficult task keeps varying up and down. I'm reminded about all the times I've had to study for my exams. The motivation to actually put down something which is pleasurable and take up something that is not pleasurable immediately for a long term gain, that motivation keeps fluctuating in all of us. So, in this style of therapy, in this style of motivation interviewing, we try as far as possible for the relationship between the client and the therapist to be equitable rather than me imparting knowledge as an expert. It's about me being a partner. You just directly scold them or fight them into it. They are far more likely to either tell you what you want to hear and then never come back, or fight again with you and break off contact right there. So the whole spirit is of the therapist and the client collaborating for a common goal, which is behavioral change. And the last point, like I mentioned before, evocation versus education. The classic example, like I've given you, in motivational interviewing, you don't read down the list of all the negative things that alcohol causes or all the problems with smoking. No, you get this out of the client. What do they know about the negative effects of alcohol and smoking? So that's about the what. So what is this technique? Just a brief intro to it. So now I'm going to move into the much more important clinically applicable how. How do we take the theory of what this technique is and use it? There are this is the most common mnemonic for uh, knowing the practices that you use in motivational interviewing, which is DARES, DARES. And I'm going to go into all of this in some detail in my next few slides. So these dares are what the therapist is aiming to do in their sessions with the person. The actual techniques we use to achieve the targets that were set out in dares are these. The mnemonic for this is ORS. So like I said, the style of
Hello?
using... Yes?
Hello?
Yes?
Hello? Hello?
I'm sorry, is someone trying to say something to me?
No, sir, you may carry on.
Okay. So the techniques that are used for achieving these targets are what's listed out in these slides. So as I mentioned before, the therapist in motivational interviewing, we often use a lot of open-ended questions because we are not trying to give information to the client. We're trying to get all of it from them. They are treated as a resource for all your information. So you wouldn't ask things like, but you know, alcohol is bad for you, right? You don't ask yes or no questions like that. You'd ask things like, what are your feelings about alcohol? What do you think alcohol has given to you in your life? So things like that, open-ended questions. So affirmations are also very important. I think this is the point Dr. Selvaraj also brought up, the importance of giving positive reinforcement, positive feedback for any change. So right from the first session onwards, right from the first appointment onwards, recognizing that this is a difficult step, that a person has admitted that their substance use is beyond their control and has come for help itself is a very difficult step. I think we all know that it's not the easiest thing to go to in an institution often a mental health care institution or a rehab facility, and admit that you have a problem. So the first interaction should start off with affirming that what they've done is a positive thing. And subsequently, at every instance, one has to look for opportunities to give a positive feedback back to this person who's doing something difficult in their life. So a technique called reflections, which again I'll talk about a little bit more later on, it is basically when we are hearing what people are saying, it is important for us to actively listen, which means I'm actively processing everything the client is saying. One way to make sure that they understand that I am listening to them, I am actively processing what they're saying, is to give them a reflection of what you thought the emotional tone of what they just said to you was. So if a person is talking about how their problems in their marriage have caused increased anxiety in them, and the only way they know how to deal with this anxiety is to drink alcohol, a reflection would be to say, I can see that you're feeling quite distressed right now, and I can see how uh, this habit might be one of the ways that you're using to cope with this distress. Am I correct in that? That you are reflecting the emotional tone, not the exact thing they said to you, but what you grasped from it. And the last thing is to summarize. This is something which most therapists will offer motivation interviewing will do by the end of the session. So you summarize what all was said and talked about today. So like for example, I'd say till now in this talk, what I have talked about is the basic funda of what is motivation interviewing, and we have just started talking about the techniques of how we're going to use it. So that could be a brief summary of what all has happened so far. So the first target in our motivational interviewing as a process, so going back to the dares that I talked to you about, is developing discrepancy. Now, what does that mean? What does a discrepancy mean? So remember what I told all of you, that studies have found, and even in personal experience, I find that by the time people have a physical dependence and by the time they reach professional help, there is usually some amount of conflict in their mind as to this substance. So discrepancy, when we talk about, is the discrepancy between what they think they should do, so their personal goals and their values and their targets, and what they are in fact doing. So a discrepancy from their thought and their behavior. So that's what we are trying to develop and further even more. We're trying to put a highlight on it, circle it, and show them. Let's see what you wanted, what your targets and goals are in your head, the kind of person you want to be in your head. For some reason, don't seem to be that person. Could that reason be your substance use? So that would be actually developing some amount of discrepancy inside them. Why this is important is, remember, this entire tactic is to increase their motivation to do this very, very difficult thing of stopping a substance that they are physically dependent to or has become an important part of their life. So this, in essence, is what's going on in the head of many people with substance dependence who are coming to you for help. All of us are in and are by nature, there is some inertia in all of us. Just like in physics, you need some amount of force to get a stationary object moving. Even psychologically, there is inertia to change. People tend to stay within the status quo. And often that is because this decisional balance that is put out in this image I've got from an organization's website, this decisional balance has not clearly tipped one side or the other. You have not clearly decided whether the costs of continuing in this status quo are more or less than the benefits. So what your job as a therapist, number one, is to try to tip the balance of this decisional uh, of the decision that is going on inside the client's mind towards change. So how do we know whether our efforts at increasing this discrepancy and our efforts at promoting change have worked at all? So we try to watch out during our sessions for talk from the patient that indicates that they might be moving towards change in their behavior. What I've labeled as change talk over here. So things like the client spontaneously bringing up disadvantages of what's going on right now. So he might say things like, I understand that I am spending a lot of money on alcohol. The financial situation at home is quite dire. Because of the financial situation and my spending, my fights with my wife are increasing. That is worsening my marital problems as well. So this kind of talk is good, prognostically speaking. We're looking for it. We're trying to see this because this is objective evidence that all of our talking and our sessions are actually reaching somewhere. So the client spontaneously coming up with advantages of change. Yes, if I quit alcohol, these are all the things I can expect will go better in my life. I am, of course, using alcohol as an example. The same model with the same format can be used across substances and really across behaviors. We can use it for any problem behavior. So if a person themselves is expressing optimism, that's a very important thing. That's one of the first things we're trying to do initially, is to build up some optimism that this is possible, that this difficult thing, though difficult, is not impossible. And then finally, if they're clearly telling you that they intend to change, then number one, your first target of having resolved their ambivalence, having tipped the decision balance towards change, that's the clearest evidence you can get that you've been successful in doing that. So there are various techniques that you can use to actually encourage people along this path of thinking about change, and I'm going to look at some of them. The most common type of technique that therapists use when in these conversations, when they're trying to elicit change, are evocative questions. So I've given some examples here. And you can see how, firstly, these are all open-ended questions because we are not trying to, it's very important that what you hear from the client, you're sure is what is going on in their head and not that they're just telling you what you want to hear. So you ask them open-ended questions. So someone who is not very sure whether they want to change at all, not very sure whether they even need to change at all. So their motivation is at the level, and we're going to look at stages later, is at the level that they have just about started thinking about quitting the substance or have not even started thinking about it. A very useful question would be to ask them, predict, if you continue drinking 360 ml of alcohol, of liquor daily for the next 5 years, what do you think will happen? And then you see, where are they? In what stage are they? Are they able to accurately predict what's going to happen? How optimistic or pessimistic are their predictions? And you take it on from there. So if you see these questions in various different angles, we are trying to basically make the person start thinking about the consequences of their current behavior, the disadvantages of continuing this current behavior, as well as trying to slowly push them into the practicalities of how will they actually be able to change this. So the next step in our dares, our target, was to avoid argumentation. Like I said before, the problem with arguing with clients are many. Number one has to realize that your power in this person's life is dictated by them. They have voluntarily come here for your help. They can at any point stop cooperating with you, at which point there is really little that you can do. So argumentation, number one, it puts your relationship with your client at strain. The rapport that you have tried to build with them might break. Number two, it's not very effective. Directly attacking and targeting fixed beliefs, fixed behavioral patterns rarely work. People get on the defensive, and they might do that in a rather aggressive manner at times, or they may retreat completely. So it's not a very effective tactic, which is why we try to avoid it during this time. So the question comes up that finally, a lot of clients do put up resistance. Even people who say that they would like change, would like to quit their habit, when one actually starts suggesting things to them, suggesting the practical ways that they need to change their life, it is quite common to encounter some resistance. Like I said, we are all status quo animals. We'll have some inertia in our behavior. So, an important tactic in motivational interviewing is that when you deal with resistance, to again not directly attack it. So if you're dealing with a lot of resistance, we don't directly say what you're saying is wrong. So for example, if uh, someone has decided, yes, I would like to quit, then using some frameworks, something like what Dr. Selvaraj said, we've identified that one of the reasons that this person finds it difficult to quit is that they come back home from work every day on the same route. On that route, there is an alcohol shop. When they see that alcohol shop, they find it impossible to control their craving. So you may suggest, why don't you change the route? At which point that person may start giving you reasons why that is not possible. So that is the kind of resistance you practically in real life see when you are giving suggestions. So what we have to do there is not to directly say all of your objections are meaningless and small. They don't really seem to matter. You can do this if you want to. That would be absolutely non-productive. So what we would do is we would ask them, okay, so what do you think you can do? You yourself are saying that this alcohol shop is a problem for you. How do you want to deal with it? Start getting solutions from them. Explore each solution. Then see which is the best solution. Or you could say, oh, you seem a little unsure about whether you would be able to do this. And you may want to go back a step and then check again. Are you sure you want to change? Are you sure you want to quit this substance? Is that clear in your head? So you can go in either ways. So this in practical terms is what we mean when we say roll with resistance. So these are some of the tactics and techniques you can use in your session to deal with resistance. Like I've mentioned before, reflection or reflective responses. So what I gave an example earlier when you're saying, oh, you seem to be upset about this, or you seem to be anxious about this. Those would be simple reflection. Amplified would be something like, in the example I gave of the person who's willing to change their route back from work till home, you could say, oh, so what you're saying is that it's impossible for you to change this route. And since you can't change this route, it will be impossible for you to quit this habit. Is that what you're saying? So that's an amplified response. This person gave you a little bit of resistance. You've amplified it to an extreme and presented to them. At which point, very often, the person will start backtracking and say, no, 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 it's not that bad. So you've actually got them on your side. Or you could give a double-sided one. So you could say things like, so that's a little confusing. Earlier on in our last session, you said you would like to change and you realize it's difficult, but are willing to do it. But now our first strategy we seem to find is too difficult for you. What is going on? So you are giving them how you are showing to them how they themselves are on both sides of this argument and how that is stopping them from changing. So that is a very classic and maybe one of the best ways of dealing with resistance. But there are of course other ways. If the resistance is very, very strong, you may want to abandon that area and say, okay, let's think about something else. Then you could try to reframe the resistance. So if the resistance is amenable to you, say finding a silver lining to it, or change the way that they are perceiving certain circumstances, that would be what is called reframing. So if a person is using, I think a good example is, again, what Dr. Selvaraj also said, about a person who has been able to quit alcohol for 90 days and has now had a lapse and had a drink and is very dejected. So from their perspective, the most important thing is the failure to continue in their abstinence. But it is important to change their point of view and point out to them that what is far more important is that they were able to stop for 90 days. You could emphasize personal choice when you're dealing with resistance, point out that, of course, at the end of the day, everything is that person's choice. These are only suggestions. Or you could have a paradoxical response. Say, oh, okay, impossible to change. You continue doing this. Again, like I said, this paradoxical response, a bit like amplified reflections. Often what we see is that people change their tactic immediately. As soon as you put this forth, people who are strongly arguing against something will start arguing. So then the next target from our DARES framework again is to express empathy. Empathy in simple terms, what it means is that we need to understand that this is a difficult process. We are asking a lot from this person. People are often trapped in these substance use cycles without even realizing how it has started. So by the time they trap, they don't know how to get out of it. So just understanding that this is tough on both sides, that would be the essence of expressing empathy. This is a small excerpt I took from a book called The Little Prince, because I felt that it exactly typifies the kind of paradoxical cycles which from the outside seem so clearly illogical to all of us. But these are the kind of cycles that maintain the habits of alcohol dependence in people. So in this particular example, the person with an alcohol dependence problem says he's drinking out of shame, and the shame is primarily because of his alcohol dependence problem. So that's the kind of cycle that is pretty common in people with substance dependence. Again, the last point with DARES framework is to support self-efficacy. From throughout the entire process, it is important to emphasize how this is something that is finally in that other person's control to an extent. They can do something about their habit, even if it is difficult. So difficult, not impossible, is the constant strategy that one goes with. But it is important to recognize that it is difficult. To pretend that it is not difficult shows that you've not exactly understood the depth of the problem there. Much like how we talked about eliciting change talk, we in the next, as we advance through motivational interviewing, start focusing on confidence talk. So when some person has decided that they definitely want to change, the next step is to make them more and more confident about actually doing that change. Similar techniques are used over there. So roughly, we can divide motivation interviewing into two phases. The first phase addresses a person who is as yet undecided whether they want to change or has decided they do not want to change. So building up the motivation itself, just say, yes, I would like to change. Now, what should I do? And phase two is where you progress after that. It is in phase two that techniques like CBT are often used. So concepts from CBT, concepts from that type of therapy can be used throughout motivation. So again, what one sees is that change is a very gradual process. Usually we depict change as spirals. So people take 3 steps forward, 2 steps back. Then again, 3 steps forward, 2 steps back. It is very rare that behavioral change happens in a linear fashion in which you're only seeing positive improvements across time. It fluctuates back and forth. This is perhaps the defining theoretical concept that underlies a lot of techniques that we are now using for substance dependence, and it has for decades. It's called the cycle of change. If you read it, you will immediately see, and if you think about your own actions and any behavior cycle that you would like to change in yourself, you'll see how this has very clear validity. It seems very obviously true. We all do work like this, that we progress from not even thinking about changing some behavior to we start thinking about changing our behavior. We start getting resources as to what we should do to change our behavior, actually do it, and then continue it. Now, at that point, you could either continue it forever and never fall back into your problem behavior, or you could relapse. Like I mentioned, the most common thing in substance dependence is multiple lapses. The usual pattern is for us to learn from each lapse and to make this entire cycle become broader and broader so that the relapses are more and more separated by time till finally they are not present. So actually, it's quite important to determine which phase is the client sitting opposite you, which phase is he in, because each phase has different techniques that you would use. It is unlikely to be very effective to immediately jump into practical suggestions to change a person's life if they are in pre-contemplation phase and have thus not even started thinking about changing their behavior. Similarly, someone who has already decided that they want to change, they are unlikely to be very impressed if you then start telling them all the reasons they should change. So you need to see which stage of this cycle is the person sitting opposite you, and the interventions that you provide in your session would then change based on the stage where they're at. So what I talked about right now are the classic motivational interviewing techniques. We use them quite often in my institute, especially for inpatients. But there is a reason why we use them especially for inpatients. This is quite time consuming. Sessions take 30 to 40 minutes at least. We often don't start off with a clearly defined number of sessions. And so many clinicians felt the need to have some techniques for their OPD use and their outpatient where they do not have the time to have 40 minutes sessions with each person. So some of the principles that we talked about were used to come up with a new module targeted primarily at clinicians sitting in their outpatients who have, say, 10 to 15 minutes to spend with a person. There again, there is a mnemonic. This topic is full of mnemonics. So the mnemonic here is frames. So what that would really look like in reality is that you're sitting in our OPD and you see someone who you realize has an alcohol dependence problem. Perhaps you are detoxing them in their withdrawal phase. You're trying to control the withdrawal. So the first thing here you will see that everything is different because you have only 15 minutes. So here you are immediately jumping in and giving information, unlike in the last one. So you immediately give some feedback on the risk. You realize the risk that you've been taking. You realize this is your second or third withdrawal with some complications. The pattern of what is happening here doesn't seem to be good. You then remind them that change can only happen from them. It can only be internal. Externally imposed change will not happen. You may want to give them some specific advice where things like the anti-craving strategies that Dr. Selvaraj mentioned would be very useful to provide at that point. The next time you really feel like drinking or really feel like smoking or whatever your target is, that craving time, use the 4Ds, for example. A menu so give them several options. You pick what is most applicable to you. So even in the 4Ds, often people are confused. What do they actually do to distract themselves? So it's important to nail down a bit of a final plan. And the last two are common. A spirit of empathy. People with substance dependence are often very sensitive to judgment and criticism. They have received a lot of judgment and criticism. They are expecting the therapist to fall into the normal pattern of judging and criticizing them. Just breaking that normal pattern itself is a very useful thing in your session, and to give them some confidence that indeed this is possible. It is not an impossible task. The slide I've got up is actually something that's used in the National Health Service in the United Kingdom. It's a brief intervention designed again for substance use. So actually what they do is they just ask one question of, from a scale of 0 to 10, how ready are you to cut back your use of whatever substance it is? Based on that one question and the score, they've actually given some plans for clinicians what to do. So you will notice again how this is a very practical modification of motivational interviewing to be used by all of us in our busy outpatient setting. and is extremely useful in a low resource setting like India. Few traps that we need to avoid when we're trying to do any do any therapy for substance dependence. It is very important that there should be a conversation. So if a person is giving you very short answers, and you just keep questioning them and they only give short answers, it's important to bring that out and say, you don't seem to be fully participating in this. Is there something going on? Is there something I can do to make you more comfortable? Don't take sides. Often in our setting, the client is brought to you by concerned family members who are very eager for you to take their side in this whole debate. It's very important right at the outset to clarify that your role is not to sit as a judge for disputes. Your role is to facilitate change. Number three, like I said, in motivational interviewing, the dynamic of the relationship between the therapist and the client is not that of an expert giving more information. It is of someone who has some skills in a certain technique, but is finally not an expert in this person's life. I also think this is just true. We are an expert. You can be an expert in motivation interviewing. You are not an expert in this person's life, their problems, their personality, what goes on in their head. Only they are experts in that. So you will have to get that information out from them and not just give them information. Don't jump into premature focus would be jumping to specific strategies before they're ready for it. So like I said, it's important to know which stage of motivation is the person sitting opposite you. It is important to recognize that stages of motivation can keep changing. So you will have to have a bit of a gauge on every session. Which stage is this person at right now? Is he stable in the motivation in that same stage, or is it fluctuating up and down? And it's important to not blame the person for their dependence. Sometimes difficult to do because when one has invested time and energy into an outcome, one also feels personally invested in this, and thus it is easy to take the next lapse into drinking or smoking or anything you're trying to change as a personal affront that something has gone wrong. That's not very productive, even if it is understandable. And later on so what often happens is that once someone has said, yes, I would like to change, in your head you think, okay, their ambivalence is gone, they have decided to change, full stop, full steam ahead, let's go on to other things. But ambivalence can keep coming back and forth. If the person is at any point you feel that there is a resistance which was not there earlier, it's important to ask them, are you still of the same mind that you were 2 weeks ago when you said you definitely want to change this habit, or has something changed? And it is important to keep giving optimism. Substance dependence can be broken. Uh, it's just something that I see every day. It can be broken. It is difficult, but you can definitely minimize the harm that it causes. There is no doubt. So why do I strongly believe that people should know about motivational interviewing? And if you are in any way involved in the mental health care industry, definitely you need to know about this. Why I would say that is, like I've mentioned before, how human beings and all of us respond to calls to change. We are all of us status quo in our heart. None of us really wants to change, even when it seems really, really obvious to those outside looking in that we need to change. So, what motivational interviewing has going for it is that it works. It works because it accepts that human beings are complex, their motivations to change are complex, and it accepts that the person sitting opposite the table from you with a substance dependence habit still follows those rules that all human beings follow. So what we know for sure till now is that in the field of substance dependence, some intervention in terms of counseling or motivational interviewing or using CBT, some intervention has uniformly been shown to be better than no intervention. Though which is better and which is worse is very unclear. We do know, however, that the factors that determine, so if you look at studies that are trying to prognosticate which people will be able to quit and which people will not. There are multiple factors, including how effective, how confident the therapist is. So that's the clinician effect. How much optimism are you able to generate in the person is a very good predictor of their ability to actually follow through with your plans. It has been found that if we record interviews and note down the number of times the person spontaneously brings up change, what I called change talk earlier, that is a good predictor of which people are managed to quit and which people do not. At the end of the day, we have mounting and very good scientific evidence for the use of techniques like motivational interviewing and substance dependence, to the point that it has almost become treatment of choice. Really. So what we are targeting for people is that they should be ready, willing, and able. If these three things are there, then we immediately can move on to more practical, real life interventions as to what they need to change in specific about their life. Thank you. These are my references.
Sir, there are questions for you from the participant side. What is the success rate of your treatment?
So personally, I in my center, we've not done any studies to show success rate. The reason for that is that we are following principles of motivational interviewing that can be used in various different forms. So there is something called motivational enhancement techniques, which is a set number of sessions, I believe 4 sessions, with a set content for each session. So you wouldn't need to do things like that to study. Overall, what we do know is that motivational interviewing definitely increases the amount of time till the next lapse. Lifelong abstinence increases, but overall rates would still hover around a quarter to 30% of people at enrollment, 25 to 30%.
Thank you, sir. You are intelligent enough to pick up and stay with the topic of motivational interviewing. Sir, you have discussed as the secrecy of motivational interviewing as our participants kept putting it in the chat box, like it has given a real insight into the practical scenario. You have shaded our axons and dendrites bright enough to move towards the clinical practical application. Thank you, sir, for your patience with time factor. It was a great presentation. Thank you.
I'm delighted to thank God Almighty for blessing us on this occasion. I'm delighted to thank Principal Madam Dr. Jayasuda, untiring leader who turns impossible into possible. My sincere thanks to the eminent speakers, Dr. Mayil Vagnan, Dr. Selvaraj, and Dr. Abhinav for their excellent coverage on the topic. My special word of gratitude to Professor Meera Saravanan, HOD, Department of Mental Health Nursing, and Mr. Bhaskaran of this institute, to all the participants from various parts of the globe who have participated and for it being the pillar of our support. And eat healthy and stay healthy. Let's all support for boost up abstinence, break up substance use, and bring out strategies. Once again, thank you all.
So I must really thank personally Dr. Selvaraj, Dr. Mayil Vagnan, and Dr. Abhinav for being excellent coverage, and many comments from the delegates has been received where a lot of them are doing the studies on this cognitive behavioral therapy also. So they said your content was excellent for them to be the source of information for their studies also. We must really personally thank from PSG, and thank you, sir, for spending your valuable time with us. Thank you, sir.
You are welcome, madam.
Thank you, ma'am. Thank you.
Okay. So we take leave. I take leave. Let me get in touch with you later. Good day to you all.
Yes,
Thank you.
thank you.
Thank you, sir.
Rajini. Oh, Rajini.